Hello?
Yeah.
Hello.
Oh,
All right, just wait for a few stragglers. And I did figure out the recording. It is recording, and I was able to play it back, so I'll send it. I just don't know how big the file is.
thank you for that.
It's not free. You pay me.
We're paying a lot.
Okay. Sure.
Oh my God, who's crunching?
Me. Sorry.
Seriously, Brittany, in class and now online?
I'm so hungry, but I will mute myself. I apologize.
Really hard.
Stop making me hungry, guys. I hear silverware there.
So you can't tell us not to eat. We're not in class.
Well, I guess I'm eating air. Let's go back. All right, can you see my screen?
Yes. Yes.
Yes, okay. All right, so let's go to signs and symptoms now. Now, on the exam, you need to distinguish between expected signs and symptoms of COPD because this is a chronic condition. So day to day, you are expected to see quote unquote normal. Well, let's not use the word normal. Let's just stay with expected. All right. So expected signs and symptoms, are they cause for alarm?
No.
No. Okay. So you just need to constantly assess, is the patient still under the expected day-to-day signs and symptoms versus are they having signs and symptoms of an exacerbation? Right. So these are because nurses are expected to do the teaching. So you need to teach the patient when is it time to call the physician. All right, and we'll get to that when we get to the interventions. But like I mentioned earlier, we'll have to go back to asthma. All right, so we'll go uh, up in the chapter shortly in order when we get to the management. Okay, so let's start with signs and symptoms. So unfortunately, the author didn't put it in a chart. I'm sure by now you love charts and tables, right? So much. Yes.
Like so much.
Yeah, I'm sure
So much.
you did it, right?
So much.
Right. And I know you're being honest with me. You can't lie. So we're not even done yet. This is only your third semester. By the time you go to your fifth semester, you'll be looking for charts and tables. All right. So if you read through the paragraph, you can create your own chart, your own table. All right. For instance, these are some questions. So obviously, if the patient's shortness of breath gets worse, then that means are they still able to finish a sentence?
No.
Not. Okay, so day to day, they may pause, every few, they may have a phrase, for instance. Okay, but if the shortness of breath is getting worse, then that means they can now be talking in every 1 to 2 words, meaning they have to catch their breath, and that's quite serious already. Okay, they can't finish an entire sentence, to talk in sentences, and then they have to pause in order to breathe to catch their breath. So that's obviously a sign of an exacerbation. Another is, let's say, what about orthopnea? Is this cause for alarm? when they can't sleep lying down flat?
No.
Not necessarily. Okay, so these patients normally sleep on a few pillows, especially if they've already developed cor pulmonale, okay, the right-sided heart failure. Here, another thing is, are they able to finish a meal? Right, because that's important. Right. So if you notice, you've been in clinical for the short time that you were in clinical before it was interrupted by Mr. Coronavirus. You've seen the schedule of the bronchodilators. What time did you notice that they were? What times did they appear on the MAR?
Before lunch. I mean, before meals.
Right. It's usually breakfast, before lunch. So usually the time is either 6 or 7 or 11 or 12 p.m. Right, and then another one at around 5 or 6 p.m. if you notice, right? And then another one at bedtime, and sometimes they get one at around midnight, 11 or 12 midnight. Okay, so this is of course to allow them to eat, so they can eat properly, and then at midnight, so they can have, you know, a more uninterrupted sleep. So this is what a typical COPD patient look like. You see the red flushed appearance. That's the polycythemia there, causing the flushed appearance because they have increased red cells. And what this patient's position is called, this is the tripod position. I think it's labeled right here. Not there, but it should be mentioned somewhere. So this is the tripod position. Okay, this is common in COPD patients. Another, right here, tripod position. Okay. So they automatically assume that. I mean, nobody taught them to do this. They just figure it out by themselves. They figure that, oh, I feel better when I sit like this. Okay. Respiratory rate. Of course, their expected day-to-day respiratory rate is over 20. No, very seldom do they stay between 12 and 20 breaths per minute. So usually they're maybe at 22, 24, but definitely 40 to 50. This is not normal, right? So, and it's clearly said here, during an exacerbation, respiratory rate will go up. I mean, if you can try this out, how long are you gonna last if you breathe 40, even just 40 times a minute?
Not long.
That means, yeah, that means you have to take 10 breaths every 15 seconds. That's almost every 1.1 second, right? And remember, normal breathing, it takes 1 second to inhale, another second to exhale, and then there's a couple seconds pause before we need another breath, right? So if you're breathing almost every 1.1 second, I mean, what else can you do? Can you chew and swallow food? If you're doing that, I mean, you're not gonna last long. Okay, so you'll have fatigue probably in a couple hours. You can't, you can't keep this up. So that's definitely an exacerbation. Another is the here, if there are already retractions, that's not normal. Okay, retractions are definitely a sign of an exacerbation, because that this thing indicates respiratory distress, meaning the patient is now using accessory, serious accessory muscles here. Breath sounds, so it tells you here, wheezes and other abnormal sounds often occur, and that means these are expected, right? Although it says here, although crackles are usually not present, so that tells you crackles is not expected. So that's definitely a sign of an exacerbation. Another one here. We see reduced breath sounds, but absent breath sounds is not expected. So if you have absent or silent chest, then that's already a possible pneumothorax. These patients have a risk for developing what's called a spontaneous pneumothorax, because long-term COPD patients develop what's called blebs. Blebs are, the best thing I can describe is, if this is your This is your lungs. Okay. So blebs are like blisters that form on the surface of the lung. Of course, when you have these blisters, these are air-filled. So what do blisters do? Just like if you have, I don't know, bubble wrap.
It burst.
Yeah, right. When you burst, then you have a hole in the lung. Okay, and these are will just spontaneously rupture, causing a hole in the lung, and air is trapped inside the pleura. Okay, the pleural sac. Okay, so that yeah, so now you have air inside the pleura, and that becomes a pneumothorax. Pneumothorax is discussed in chapter 32, so we won't worry about that right now.
Professor,
Yes.
you went out during that conversation. Your whole thing sounded like you were underwater. Can you repeat some of that, please?
Which part did you lose me?
Blisters and blubs. When you get that, then there's a hole in the lung, and then after that, everything went sideways.
Oh, okay. What I said there was this is one cause of a spontaneous pneumothorax, meaning as long as you have a hole here now, for instance, a hole, that means every time you inhale, the
No,
air.
no, it's happening again.
Sorry.
It's happening again.
Don't forget. Don't worry about it. We'll just skip that because I'm not testing you with pneumothorax yet.
And clearly it's not meant for us to get it because you keep cutting out at the same part.
All right, another expected change is a barrel chest. So if you picture the emphysema lungs, a hyperinflated lung, so the anterior posterior diameter now will change. So normally your chest would be shaped like this. So if this is, let's say this is Christina's nose right here, and we're looking at her on top. So let's cut off Christina's head, and this is now her chest. Okay, so you have the mediastinum there, and then you have the lungs here. In a person with emphysema, because the lungs are hyperinflated, it will now be like this. So you have the mediastinum there, so leaving you with less area for lung expansion, because this is supposed to be like this. So this diameter here is 1:2. Okay, so you can see 1:2. Now this one is almost 1:1.
Professor, are we supposed to see a drawing? Because I don't see anything.
Yeah, I don't see one either. I just see the clubbing.
Yeah, I see the picture of the fingers.
Oh, because I didn't share that. Okay, so new share. You see it now?
Yeah.
I don't know what I'm looking at.
Okay, so
Yeah.
this is the
Other
okay, let
one.
me start over. Eraser. Oh. All right, so rewind.
We're crying.
All right, so let's say this is Christina's nose, okay? And this is her chest wall. And so that's Christina, and this is somebody with emphysema. So as you can see, her anterior posterior diameter is 1:2. So this is anterior, this is posterior. I mean, anterior, posterior, and lateral diameter. And this one is almost equal. Okay, 1:1. So that means she has her heart here, and there is larger area for the lungs to expand there. Whereas this one, the heart's the same, but then leaving you with less surface area for lung expansion when you have a barrel chest. You get the point?
Yeah.
Okay.
Yeah.
Yes.
All right, so that's an expected change, of course. And another expected change is the color. Okay, so the patients usually have a dusky appearance. Okay, it may be masked if the patient is Caucasian and has that flushed look from polycythemia. Another is this change in the clubbing. Now, clubbing of the fingers is indicative of chronic ischemia, meaning if over time the peripheral circulation is deprived of oxygen constantly, this is the result. So this is like a compensatory, what is this, modeling of the fingertips. Okay, this is not exclusive to COPD. This can also be seen in, say, heart failure as well. Okay, so
Can you go back to your book, please?
I am on the book.
No, I see your picture.
Yeah, you're not
Yeah.
on the book, Professor.
It's still on the Microsoft. Yeah, there we go.
What now?
Thank you.
Okay, all right. So here's the barrel chest, and then here is the clubbing of the fingers. Of course, these are expected. Okay, and then we already discussed the core pulmonale signs and symptoms. Psychosocial, if you notice, if you haven't already, with every chapter, whenever we talk about psychosocial, that's why I like to repeat it, because it's really the same. I mean, imagine yourself having this, and let's say you are, I don't know, 40 years old. Sorry?
Your microphone is having a lot of difficulties.
How about now?
Sounds better.
It's better.
They really didn't do anything.
I don't know what's going on with your microphone, but the minute you go into something that seems very important, you go in and out, you sound like you're underwater.
Oh, actually, there's some flooding here in the office. What I was saying about psychosocial effects is, imagine yourself having this kind of life, having to think about breathing. Are you able to socialize normally? Spend time with your family?
No, all you're thinking about is your breathing.
Right, your partner, so that everything will suffer. As mentioned here, work, family, social, and even sexual roles are affected. So of course you can see how this will affect the patient. Okay, and it's pretty much the same from one chapter to the next. Right, so I'll just mention this once, and then of course you use your imagination or simply read on the next chapters. Okay. Right. So these patients, as I mentioned earlier, will have compensated respiratory acidosis, although sometimes during periods of exacerbation, they may go initially into respiratory alkalosis or even metabolic alkalosis when they come into the ER. I already mentioned the polycythemia. Again, this is a compensatory increase in red blood cells. This will explain the flushed appearance. And of course, x-rays will show the cardiac changes in addition to the hyperinflated lungs and the flattened diaphragm. Table 30-2. This one, because COPD is diagnosed using FEV1. Now, this is accomplished using a spirometer. Let me go back here. Can you see the whiteboard?
Yeah.
Okay.
Yes.
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 So in what was I supposed to draw? What was I saying?
Barometer.
Okay.
The FEV1.
Right, a spirometer. A spirometer is used to perform a pulmonary function test. That's what PFT stands for. So a pulmonary function test. Now this test is using a spirometer. If you look online or YouTube, you'll see this is a big machine with different hoses. Now the patient will be doing this in a doctor's office. It is not done in a hospital simply because we need you to be well when we perform PFTs. Okay, PFTs are only done during a well visit, meaning the patient obviously has COPD, but then they must not have an exacerbation when they perform this, because of course, when we perform the PFT, we are measuring the pulmonary function test of somebody with an exacerbation, which is not baseline. All right. So one of the this machine, of course, will be measuring several things like total lung capacity, residual volume. Okay. One of the tests which is accomplished by blowing into this thing is FEV1. This is forced expiratory volume in 1 second. Okay, so as you can see on the table here, right, if you go to table 30-2, the lower the FEV1, the more severe the patient's COPD. All right, meaning FEV1 of less than 30%. I mean, that's pretty bad, meaning they can only blow, or their lungs have only less than 30% capacity. Okay, so that means you can see how hyperinflated the lung is, how weak the lungs are. Okay, if they can't blow enough volume, so let's say we want at least definitely way higher than 80 here, that's normal. If you're already at less than 30% at very severe classification, then you're probably in a, remember a heart failure classification when we discussed it under chapter 35?
Yes.
Yeah, so it's pretty much the same level already. So if they're at gold 4, then these people are awaiting lung transplant. Yeah, or just pre-departure. Next is interventions now. We have standard interventions for any respiratory condition. Now, take note that your textbook uses exemplars. So this is a concept-based textbook. So if it's a respiratory problem and it says here that the patient you're going to monitor these, teach these breathing techniques, which are enumerated in or listed in chart 30-10. And then here, positioning, coughing, oxygen, and then drugs will go back to asthma, exercise, suctioning, hydration. Now, these are not exclusive to COPD, okay? So when we go to pneumonia later, and when we go to tuberculosis, and then later in your 5th semester, we'll go back to chapter 32 and we'll talk about pulmonary embolism, acute respiratory failure, etc. We have the same assessments, the same interventions. Is that clear? Mm-hmm. Okay, so meaning for every respiratory patient, you monitor the same things, you teach them the same breathing techniques, you do exercise, suction as needed, etc. Clear?
Yeah.
All right, so let's guess I don't have to keep repeating this later when we get to pneumonia and tuberculosis, okay? Because it's already all discussed here. So monitoring. You can, of course, start with vital signs, then draw ABGs if needed, because that's the only way we can determine hypercapnia, is if you have ABG. Breathing techniques. So you know that the diaphragm is flattened, so that's no good. So you'll have to teach them to use other muscles here, because again, the diaphragm is of no good to these patients. It's already flattened, it's pretty weak, so you'll have to use other muscles in breathing now. So this is why we use abdominal breathing. Okay, so it's not really again the diaphragm, but it's more abdominal. So here they're using their abdominal muscles in order to augment their diaphragm in breathing. Another is pursed lip breathing, and you clearly have the instructions here. So these will all be in the exam questions, either the abdominal breathing or the pursed lip breathing. These are the two most commonly used techniques. This one, for some reason, COPD patients learn it on their own. I mean, if you ask them, who taught you that? They'll say, I just figured it out. So in pursed lip breathing, if you follow the instructions here, this ends up prolonging the exhalation phase of the breathing, of ventilation, sorry. Normally the inhalation to exhalation ratio is 1:1 or 1:1.5. That means seconds, okay? Meaning it takes a second to breathe, 1 second or 1.5 seconds to exhale. In pursed lip breathing, you extend the exhalation phase up to 4 seconds or even less. So you can go 1 second to inhale, and then 2 seconds, 3 seconds, or up to 4 seconds to exhale. Okay, so as stated here, spend twice the amount of time when you breathe out. Okay, so at least twice the amount of time, so that's 2 seconds or even 3 or even 4, right? So this prolongs the exhalation phase, so therefore what's the effect if you exhale longer? When you have air trapping, when you have a barrel chest, what will that do? How will you benefit from this breathing?
It allows you to get enough oxygen in.
Anybody?
You would excrete more CO2.
Exactly. So that's the benefit from this breathing exercise. The patient ends up exhaling more CO2. Positioning. You saw the tripod position earlier, or the orthopnic position, which is the one you saw where the patient was leaning over 2 pillows on the bedside table. Okay, so those are all orthopnic or even the tripod position. Coughing. So the patients need to cough effectively. This is no different from the coughing exercise or technique you taught Miss Lillian Chambers, if you remember from last semester.
Mm-hmm.
All right, so that's here, hugging a pillow against the stomach, then bending forward to, kind of push and use your abdominal muscles, okay, and support it as you cough. And you did this, right? You still did like 3 times. Yeah, if you remember the technique. Because again, this is not different from what you learned in fundamentals of nursing. Oxygen. What did you learn about COPD patients and oxygen therapy?
They can't go above 2 liters.
Okay. So that tells you here, right? It says patient with COPD may need an oxygen flow of 2 to 4 liters by a cannula or up to 40% by a mask. However, thank you, Leslie, for reading this highlighted section here.
Oh. hold on. Okay.
In the past.
Oh, I got it. I got it. In the past, the patient with COPD was thought to be at risk for extreme hypoventilation with oxygen therapy because of a decreased drive to breathe as blood oxygen levels rose. However, this concern has not been shown to be evidence-based and has been responsible for effective management of hypoxia in
Ineffective.
patients.
Responsible for ineffective.
Oh, sorry. Ineffective management of hypoxia in patients with COPD. All hypoxic patients, even those with COPD and hypercarbia, should receive oxygen therapy at rates appropriate to reduce hypoxia and bring SpO2 levels up between 88% and 92%.
All right, so compare that paragraph with the preceding one where it says the patient, or what you learn in fundamentals, wherein the patient only receives 2 to 4 liters. So which one applies now?
Not true.
And it says clearly, right, that in the past, yes, but theoretically speaking, this is true. I mean, it only makes sense that if more oxygen will decrease the drive to breathe, correct? But these patients have chronic hypoxemia, they have chronic hypercarbia. So yes, again, I'd like to emphasize, theoretically, this is correct. However, is it evidence-based?
No.
No. So, and meaning there is really no evidence that this will happen. But theoretically, yes, this is what's going to happen. But again, there's no evidence really, because even when, especially if these patients are intubated already, we actually give them more than 2 to 4 liters, and it makes them better. All right.